TopMedTalk.
Hello and welcome to TopMedTalk. This is Desiree Chappell coming to you from the American Association of Nurse Anesthetists 2023 Annual Congress in Seattle, Washington. We are joining you from the North Star Anesthesia booth. It's been a fabulous meeting so far, and things are a buzz here at AANA 2023. This is the largest gathering of CRNAs in the country. Actually from all over the world, not that there's a ton in other places in the world, but we're all here together celebrating our profession. We do want to thank North Star, our sponsors, for giving us a little niche here in their booth. We have some nice comfy chairs to be able to talk to all of our TopMedTalk guests. And of course, thank you to Edwards Lifesciences, who have been a major sponsor for us and really help us to keep TopMedTalk free and open access to the world to provide medical education. So thank you to them. Now, it's my pleasure to introduce some colleagues that I'm going to be presenting with over the next couple of days on a topic that is near and dear to my heart. We talk a lot about it on TopMedTalk, is intraoperative hypotension and hemodynamic instability. So here at the AANA, we're going to be doing a lecture on IOH, the impact that it has on our patients, and talking about ways that we can intervene and hopefully avoid hypotension to avoid negative outcomes for our patients, because it's all about the patient. So pleasure to introduce colleagues. Amy Yerdon, who is from University of Alabama, Birmingham. Amy, thank you so much for joining us.
Thank you so much for having me, Desiree. It's wonderful to be here.
Yeah, finally.
Yeah.
We've been working on this project for a while. Actually, Amy, you and I worked on a project with the AANA on intraoperative hypotension. We did a little video and wrote an article that was published earlier, I guess late last year.
Right. Yeah. The article came out in December and then they attached the video to it in January.
Yeah. Tell everybody what the name of our article was, because I think it's awesome.
Intraoperative hypertension, killing them softly.
Yeah. So we really wanted to highlight the fact that we can have an impact on IOH as nurse anesthetists and team anesthesia in general. So looking forward to doing further work with you on that. Also want to bring in our colleague, Bradley Steg, who's from Tennessee. Is a CRNA there. Bradley, thank you so much for joining us.
Thank you so much for having me. This is my first podcast and first time being at AANA. So I'm loving it.
I'm glad we could be your first today. And I hope you've enjoyed the meeting so far. It's been pretty good. Huh?
It's awesome. Yes. Loving it.
Yeah. Lots of buzz. It's so wonderful to be able to network, meet new people, see old friends. It really is a fantastic meeting. So guys, we are going to be giving this presentation tomorrow, and I thought we'd just take a little bit of time and kind of walk through broad overview some of the things that, again, we've talked about on TopMedTalk, but are really important to us as clinicians that work on the ground every single day. So, Amy, why don't you start us off a little bit about, where we are actually starting in our journey tomorrow during the presentation and how we're kind of setting the stage?
Yeah, so we want to make sure that people really understand what we're talking about when we mention intraoperative hypotension and what that means for the patients. And there's just so many studies that have come out in the last several years. The definition varies depending on which study you look at, but kind of the common consensus is a mean arterial pressure less than 65 millimeters of mercury for at least 1 minute. Some studies look at all the way up to 15 minutes. And intraop hypotension is associated with negative patient outcomes, specifically mortality, acute kidney injury, and myocardial injury after non-cardiac surgery, or MINS. And the lower we go with that mean arterial pressure and the longer that we allow that to happen, the more the risk increases for our patients. So the depth and the duration is really what we're talking about. And we need to be minimizing that as much as possible so that we can hopefully prevent those negative outcomes.
Yeah. We also are talking a little bit about how much blood pressure we might be missing. Now, we've had numerous conversations with Bernd Sogel, who has come out with the DETECT trial and the AWAKE trial in this last year. So we've gone deep on that. So if you want to hear more information, but I want to ask Bradley, you're kind of a little bit newer CRNA, but at least compared to the old guard here. Thinking about, hypotension and how much we actually have. Did you, once you started getting into this, did you really feel like, yeah, I'm having this problem? And then were you kind of curious about how much hypotension was actually happening or that you may be missing?
Yeah, definitely. I mean, the more we research this together and look into it, it's surprising how much all of us as CRNAs were missing. With our traditional monitors, oscillometric blood pressure cuffs, things like that, we kind of dig into it with some of the research studies, but even with frequent cycles, we are missing a lot of intraoperative hypotension. So a lot of it too is, our young, healthy patients and provider specific. So it's just very interesting to see how much is actually happening that we're missing.
Yeah.
And what is a frequent?
Yeah. I mean, that's also subjective.
I know. Very, very true.
It depends on the day of the week.
I get it, right? From the perspective of clinicians, we also then talk about, okay, well, if IOH is a problem, what do we do to treat it? And I know that over the last, 5 to 10 years, use of vasopressors have gone up. I think in the context of enhanced recovery with fluid restrictive protocols, if you don't have volume to treat it, what do you have at your fingertips? Well, vasopressors is usually the first one. They are pre-mixed already for you, ready to go. That's going to be the first thing. And that may not be the right choice.
That's right. There's a lot of really good articles that have just come out in the last, year or two that are showing, yeah, maybe we've reduced our occurrence of intraop hypotension in some populations, but with the use of phenylephrine and other vasopressors going up, there's an associated increased occurrence of acute kidney injury.
Yeah.
So yeah, we're fixing some of the intraop hypotension, but we're covering it up.
Yeah.
We are fixing the number, but we're not fixing the problem, and we're actually causing more harm with that. And then also with our fluid reduction, with our fluid restriction, that's causing acute kidney injury as well.
Yeah. And I mean, AKI, there's been some recent, research out by French and his team and Pravatsky, I think back a couple of years ago, talking about the inpatient effect, cost and mortality for AKI. Even stage 1, which is we've always traditionally thought of like a little bump. And again, we've had numerous conversations with, world preeminent authorities in renal and fluid management, all these things. But I think as the everyday clinician, like you don't think, you're not thinking AKI. We don't ever know when our patients actually even have an AKI. And it's been shown inpatient increased risk in morbidity, mortality, and cost. After 1 year. And now lots of research pointing to that even just one episode of AKI can lead to chronic renal failure over a lifetime.
Right. It's like you think of acute kidney injury as like a scar on the kidney, basically. And then now you've got reduced renal reserve. So the kidney's not going to tolerate hypotension or other episodes very well after that. So that's why they're so much more likely to progress to chronic kidney disease. And how often do we know if that ever happened before in a previous surgery? We don't know that.
Yeah. No, we don't have that information at all. So we always have to do the best we can by our patients. So, for us, we are all active users of advanced technology in the OR. I think all of us are passionate about having more information to guide what we are doing. And, so we are talking about using the Edwards technology, the advanced hemodynamic parameters, and some of the newer technology that's come out. They're, newest generation of AI generated or AI informed predictive analytics or predictive indicators of hypotension. HPI, hypotension predictive index, which again, we've talked about here on the show. But how does that work for you, Bradley? I know you've used this in the context of both cardiac and, in the suites, as I call it. How has it been working for you? Is this, what do you see as the value of using this technology as someone that does it every day?
Right. I think the value is just, I feel like as a provider, it cues me into kind of what I already knew sooner. And I think that's critical for our patients. I think that we're all trained and we're educated and we know what we're doing. But, a lot is happening in the ORs. We're moving quickly. So to have just a reminder of, hey, heads up, this could be happening soon. And that's what HPI does for me. You kind of get busy with a case and you look up and you see your HPI trending. This advanced hemodynamic monitoring takes that to a level, says, okay, there's some sort of instability within the circuit here. And then it kind of tells you what the next step could be. It's like, hey, check out your preload, check out your contractility. And if those are good, go ahead and move on to a pressure. But it just gives you some information that we can't give ourselves sometimes.
Yeah. And Amy, you're an educator. That's your business now.
Right. Full-time faculty.
Yeah, you are. You still get into the OR.
Every Wednesday.
Yeah, using this technology.
Yeah.
What are you telling your students about adoption of technology? Because this is kind of one of those pieces. I think Bradley hit the nail on the head. We all know what we're doing. A lot of us do it very, very well. That doesn't mean we don't necessarily need tools to help us even do it even better.
Right. So, when I teach them right before they start clinical, we talk about how we should be doing it with this fill flow pressure and to look at whatever tools are available at their various clinical sites, because not every hospital may have the technology. If you've got it, you should use it because it is additional information. We should, just like you said, use everything that we have at our disposal to do the best job that we can for our patients. And at the hospital that I practice at every week, we do have the hemisphere monitor. So I use a lot of cardiac output index, stroke volume variation. We don't have the HPI technology at my hospital just yet.
Been evaluating it, but not been able to use that. Yeah.
And it's just so helpful. And it's a great lesson every time I have a student with me in the OR. I'm like, this is how we use this information. And every time a CRNA comes to give me a break or a lunch, they look at the monitor and like, I know what these numbers are, but I don't really know how to use this. So I give them the quick rundown and they come back from lunch. They're like, you know what? This was really good information to have. That's what I've been saying.
Yeah. You know, one of the examples that I always use for change adoption and the adoption of new technology, really any of the technology that you see now that's coming to the ORs, because it's all pretty advanced. I mean, there's some, maybe basic stuff, but I think for the most part, we're seeing AI really coming in, and a lot of people are really nervous about that. I had a conversation with the developer the other day, and they were talking about all this stuff about AI, and I was like, he brought in ChatGPT. I was like, you might want to pump the brakes on that just a little bit, because a lot of people are very concerned. Then they don't know what it is. They don't know how to use it and what it means for them, like personally and definitely professionally. Right. I think when we talk about AI, I think relating it back to what we're already seeing and using in everyday practice. And one of the biggest examples that I use is your navigation system. So Waze, right? Yeah. Waze is all AI based. I mean, there's real-time information, but it also has a ton of predictive pieces to it that says, when's the best time to leave? What are you going to be anticipating? There's bad traffic here in a couple hours, all of that stuff. And I don't know about you guys, but like, I don't go pick up my kids who are 15 minutes away during rush hour without looking at the navigation system. Can I get there with my blindfolded and know all the turns? Absolutely. But do I know how to anticipate if there's an accident, which there's a corridor that I go down, that it's always an accident there, or, more than likely there will be something. We're already using it to help us live our lives better. And, some people may say maybe not so much, but I think for the most of us, navigation is a perfect example. You don't go
bumps in the road
to avoid bumps in the road, to avoid those road barriers, to avoid those shutdowns of major thoroughfares. If there's new traffic patterns or road construction, there's all of those things that we'll always come across. So it's not that scary. I'm still using my brain. I know where I'm going. I'm just getting a little bit more information to get there faster without accident.
That's always my last thing I say is it's just more information.
It's just more information. That's right.
Don't be scared to try it.
Don't be. Yeah, that's right. Just at least pull technology in. And it's not just this technology. It's any technology. Pull it in. See if it is consistent with what you're doing. Gain some faith in it and figure out how to best use it and integrate it into your practice, because we owe our patients that. Is there a better way? Can I do better? Like I said, I know I keep saying this, and I'm actually referring to myself as pretty old, but as someone who's been doing this for a while, I know I can do it better, and I want to do that. So guys, we're going to catch up after the session tomorrow, maybe in a couple of weeks, and give ourselves a little bit of break, and catch up and see what some of the big questions were from the audience. And this is a great group of CRNAs and SRNAs as well, who are going to be there tomorrow. We want to get some, feedback and figure out what the questions really are of those people on the front line. So we'll be coming back and talking about those and hopefully answering them as well. So thanks for taking the time to sit with me, guys.
Thank you for having us.
Of course. Thank you, Sia. So thank you for having us.
Thank you so much for listening. You can always find us at TopMedTalk.com. Over 2,000 podcasts. As you know, if you're a regular TopMedTalk listener, there's lots of information on this very subject, lots of different anesthesia topics in general. Don't hesitate to do a search there and find what you can on different topics. You can also find us on your favorite social media platform, LinkedIn, Facebook, Twitter. We're all over that. And be sure to check us out at the next meeting coming up. So thanks so much for listening. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.